Hello, good evening, everyone. On behalf of ISCCP, we welcome you all to this very, very interesting webinar. Again, on the 7th of every month, so 7th of May today, for 70 minutes for 7 p.m. We ensure that we will be really keeping you engrossed and active in this very, very interesting topic, which is on use of artificial intelligence in cervical cancer screening. We have a galaxy of faculty with us who's going to share their own personal experiences also. And so before that, as I would now like to invite Dr. Aruna Nigam ma'am. Ma'am is the president of ISCCP. Ma'am, over to you. Please give the welcome address.
Thank you. So a very warm welcome to all of you, to all the ISCCP members and the other members also. Our webinars are becoming more and more popular. And just I would like to add today that this time many of the members have done the activity under ISCCP during the World Immunization Week. So I'm thankful to all of them who have done the programs under the banner of ISCCP. And I would request all of you to do more and more programs under ISCCP and be eligible for the Goodwill Award by ISCCP and the annual conference ISCCP Con 2027. And with this, I hand over the mic to Dr. Nidhi Gupta to conduct the today's session on artificial intelligence, a much awaited topic to be talked on. Thank you.
Thank you so much, ma'am. Thanks to Dr. Aruna and Dr. Bindya ma'am to give me the opportunity for conducting a webinar on such a novice topic, that is AI in cervical cancer screening. So without wasting much more time, we will start the session. And for starting the session, I will hand over the mic to Dr. Priyanka. She is senior resident at Hamdard Institute. So she will be starting the session.
Thank you, ma'am. Good evening, respected esteemed faculty. It is my great pleasure to welcome you all to today's insightful session under ICCP monthly webinar. To begin with the session, first session on introduction on artificial intelligence. Chairperson of the session I welcome Dr. Bharti Abhyankar ma'am, consultant at Purva Hospital, Kolhapur. She is Vice President of Maharashtra Obstetric and Gynecology Societies and Executive Member of ISCCP. She has worked as Chairperson on Preventive Oncology Committee, AMOG, and conducted various colposcopy courses. Our next chairperson, I welcome Dr. Veena Acharya ma'am, Senior Consultant and HOD, Rajasthan Hospital, Chairperson of ICMCH Narchi, National Executive Member of ICCP, and President of Joint Jaipur Fertility Society. The session is presented by Dr. Fahimida Bano ma'am, Director of Famicare Hospital. She has worked as a teaching faculty in medical college in India and abroad and has published multiple papers in national and international journals. Ma'am, over to you.
Thank you very much for your kind introduction. Namaste, the teacher of teacher, Dr. Veena Acharya madam, and my dear friend. Just I'm starting my PPT. Are you ready?
आप अलाउ को क्लिक कर दीजिए प्लीज. अलाउ लिखा रहा है, उसे क्लिक कर दीजिए. अलाउ.
Okay. Very good evening, my dear chairpersons, Veena madam and Dr. Abhankar. We have enjoyed your national conference.
Thank you.
Really wonderful that you both are my chairpersons. And I thank Dr. Aruna Nigam for giving me this opportunity. AI is fastly expanding, and it is not easy to tell just in 15 minutes justification to AI, but it will be like a just introduction to sensitize the young doctors what is AI can do. AI can do many things. This is also a robo with the AI. So AI can be emotional, AI can be naughty, AI can be angry. Everywhere AI is there. Just to make you understand the power of AI, the world's fastest computer, 7,000 researchers working together for more than 3 trillion years. It is called as 1 exaflop. AI can finish in 1 second. It is amazing, but yes, it is true. It is really more specific. Earlier, before 10 years, I used to think AI cannot supersede us. We are always better than AI. But now I have changed my opinion. In the last 1 decade, I have been continuously reading about AI, and I understood AI can do more precise work. It can pick up whichever color, whichever size you want. It can pick up and work more efficiently.
Hi, Sophia.
Than the
Hello.
humans.
My God. Do you know where you are? Of course. I'm in New York City, and I'm on my favorite show, The Tonight Show.
So it can do many things. So what it is doing in medicine, it is working at the various level. At the patient level, it enables them to process their own data and promote individual health. At health system, it improves the work outflow and reduces the medical errors and increases the efficiency of the doctors and the healthcare providers. At clinicians level, rapid and accurate image interpretation. So colposcopy has adopted AI and it has revolutionized the output. With the help of complex algorithms, AI can automatically recognize images, extract features, learn classification, and process data. The application of AI can, in cervical pathology, even in the remote areas, it can provide the expert opinion. When AI is incorporated with the patient history and various variables like age, whether the patient is having history of smoking, whether she had HPV positive, what is the contraception she is using, what is her marriage age, when her sexual life started, whether any sexually transmitted diseases, and previous, if all this is incorporated, all these will be included in the algorithms and prediction of cervical cancer will become more accurate. So all these models can be worked either totally computerized or a hybrid mode. There are various studies are available for the students who are interested, okay, how this works. The performance of AI in the cervical cancer screening is better than the conventional and manual methods. In hybrid approach, combined algorithms and techniques can be incorporated. They will reduce significantly the analysis time and increases the precision and thereby it reduces the cost. These advancements have also improved patients' access to the expert and prompt cytology result. Earlier, people used to wonder whether it is cost effective. Yes, it is cost effective because though there is an initial investment, in the end, the output will be tremendously more. In 2021, Cow and his workers performed AI-assisted reading compared with the pathologist and cytologist. They have came to know the AI-based reporting is 380 times faster than the typical pathologist studying that. And these algorithms distinguish between normal and abnormal, almost the accuracy is 80 to 100%. And when they compared more than 4,000 patients' reports with the researchers and with the AI, they have came to know lower rate of positive test, better sensitivity and high specificity in AI compared to the manual methods and reduced referral to the colposcopes because the dual staining based referrals compared to the only pathologist screening cytology, it is much, much less. So artificial intelligence, when it is incorporated dual stain techniques, what is dual stain techniques? When the slide is incorporated to detect protein P16, a tumor suppressor gene and Ki67, which indicates the proliferation of the cells in the cervical sample, which is also approved by FDA in March 2020. By involving the deep learning, we can determine the cervical cells in the dual staining method. What is the risk of this particular patient prone for the progression of the disease? when compared with the AI and the manual, the pathologist accuracy was 93.7, whereas AI is 98%. The time taken by seasoned pathologist was nearly 15 minutes, whereas AI incorporated techniques is taking only 0.04 seconds. This is a typical dual stained cytology slide. If you concentrate in the center, it is labeled as both the proteins positive. In the center, it is indicating 98.75% positive result. This slide is a dual stained AI red slide. The effort of a cytologist to detect a morphological change in the lesion with 20,000 to 50,000 cells in a single slide, which could be very tedious, the AI can do in a fraction of the second. The automatic smear analysis is possible because of image acquisition, pre-processing, segmentation, feature extraction, and classification. Because it is only introduction, I'm just mentioning this, otherwise it is a very elaborate. So AI makes automatic and accurate segmentation of the cervical cells. The first step in cytological diagnosis is identification of the cells based on the nuclear and cytoplasmic abnormalities and their respective structural components. The time-intensive manual segment is subject of shortcomings, and this can be overcome by AI. Again, in this, there are two types, which involves both nucleus, cytoplasm, and background. Automatic multi-labeled classification with accuracy of 93%, or some other module only concentrating on the nucleus, the sensitivity could be 92%. The segmentation model based on the mask recognition of computerized neural network architect. It takes the slides, it takes the images, analyzes them, and to classify them and compare them with the millions of images which has already fed into the AI, then it gives a more accurate report. There are a lot of architects which you can follow just to sensitize you. The least square support, multi-layer perception, random forest, all these are various neural networks. The accuracy could vary up to 98 to 99%, which is very unimaginable when we do manually. So 6 different convolutional neural networks are usually used in detecting the CNN. There are various studies supporting it. There is also use of deep learning algorithms combined with digital microholography, which says the accuracy can be improved and pushed to 100% in detecting HPV 16, DNA, and 18. There are various studies supporting it. What it is doing in CAN, AI can classify cervical cells to guide triage and improve the detection of CAN compared to the standard pathological biopsy reports. With the development of microscope, with the augmented reality, the cervical cytology screening, they can classify whether it is a LSIL or HSIL. Various studies once again supporting that. There is a prospective cohort study involving more than 7 lakh women has been done already, and the results are available. So application of convolutional neural network in colposcopy will capture all these images. You can see in the slide down, this takes the input and it compares them with the convolutional layers, and these, like our neural network, they work and they will analyze and they will classify, and then it gives the report. Using the digital microscope slide scanner, this can be quickly do PAP screening and analyze. So one more thing is diagnosis by colposcopic artificial intelligence auxiliary diagnostic system. This is utilized in colposcopy to analyze the colposcopic images. A seasoned colposcopist might have seen 10,000 pictures of colposcopy, whereas AI incorporated colposcope will have innumerable images, so its accuracy is much superior. So my earlier belief that we are superior has been vanished. AI is far superior. It is going to supersede us in many things. This system developed by Zhu et al. and it has studied more than 19,000 patients and they have proved it is more accurate. This is used to diagnose the cervical lesions, to diagnose the dysplasias, also to diagnose HPV status and grading of the colposcopic impressions and featuring the encoding graph convolution network based on the fusion. So this segmentation works gives more accurate report. So this is, for example, it also guide the colposcopists where to take the biopsy. There is a study comparing the white rings and blue rings. The white represent the predicted abnormal area and the blue has the biopsy taken and almost both are equally coinciding. That means the A guiding the colposcopist, the area to be taken biopsy is very, very accurate. So the agreement between these two is almost 82%. There are various machine learning algorithms. This is beyond the scope of today's class. So I'm just introducing. There are various things, and usually it is the deep learning and CNN methods which are accepted. And they also analyze what is the time taken by a human to become the master in this. There are also a lot of papers on this. Eventually, the hybrid assembled technique is more better. The agreement rate between the manual and the AI is 95% and accuracy of AI in screening CAN 1 to 3 in even adenocarcinoma in situ is improved from 67 to 90 plus. So AI incorporated in the PAP, AI incorporated in detecting HPV, AI incorporated in detecting the cancer proteins as well as colposcopy is going to revolutionize our colposcopy training and practice. So AI is going to become a powerful adjunct in all aspects. So the last component is how consistent it is. It is very consistent because even the human performance is subjected by the fatigability of the pathologist, his experience and training and the time taken to learn and practice. Whereas AI performance is standardized, it is reproducible. Same output, same with the same input is always available. And one more thing is the inter-observer changes with the various pathologists or colposcopists is the biased, whereas AI overcomes this and uniform quality of the care always available. So improved diagnostic accuracy, high sensitivity for detecting CIN 2 plus lesions, better specificity in differentiating benign versus precancerous lesions. Humans may miss subtle high-grade lesions, overcall benign findings. Pardon, madam? Hello?
Somebody was talking, madam.
No, continue,
Nothing,
madam.
ma'am.
You can
Continue,
continue.
madam. Continue.
You can continue, ma'am.
So humans may miss subtle high-grade lesions. And if my time is up, I will stop, Dr. Nidhi.
No, ma'am. You can take more 5 minutes more.
So humans sometimes overcall benign lesions, whereas AI will give the accurate results, probability scores, and risk stratification will be done. And these are evidence-based decisions. So definitely there will be less medical legal issues because medical legal issues are becoming very often nowadays. So it will give more assurity to the pathologist and to the clinician. So comparison with the manual, superior pattern recognition. AI depends on the pattern recognition. It compares with the previous images in his memory. So it will analyze millions of images in a fraction of the second. It detects subtle changes like acetobite areas, mosaic patterns, atypical vascularity. Whereas humans' vision is limited with the fatigability or with the experience, whereas AI can detect invisible lesions which are missed by the human eye and also leads to more accurate diagnosis. So these are the some of the images and this is getting incorporated into the newer colposcope. Newer colposcopes itself is a big class. I will just mention one or two slides and then conclude. Newer colposcope incorporating AI has become a ergonomically comfortable to the colposcopist. Otherwise, we have to adjust the colposcope, neck bending, twisting. All this is not there. So workflow efficiency has tremendously improved. The hands are free of the colposcopist, and they look at the screen like how we do laparoscopy and hysteroscopy. Even colposcopy, we look at the big screen and beautiful visualization of the lesion will be there. It enhances the examiner comfort during prolonged procedure and supports uniform reporting aligned by the AFCPC terminology, reduces subjective variability and interpretation, empowering colposcope and colposcopists with enhanced visualization, documentation, and clinical confidence. So, compared to the older colposcope evaluation, the newer ones, you can be very accurate, less fatigability, ergonomically better. So, this integrated documentation system can capture the image, store the image, and whenever you want, you can retrieve the image. Even you can make a video, and you can even add that terminologies as we are doing in our colposcopy society, and you can label the lesions, you can draw the graph. It becomes very easy to teach, to exchange the images with our colleagues, to discuss, and when we need, we can take a second opinion. We can just send the images to Nidhi or Aruna Nigam and take their opinion. That will be in a fraction of a second, and it is very useful for the future fellows to get trained by the various experts. This is one quick video of 1 minute where the colposcopy is doing a incorporated one. It is also can adjust the degree of insert through the Cusco. It is passed and the image will be on the screen, and you can choose and whichever area you want to take the picture, and in a fraction of the second it not only gives the picture, it also giving the opinion. I feel it is going to be a revolutionized method of learning and practicing colposcopy in future. So any suspicious area, anything you want to discuss with your seniors or colleagues, you can. And you can generate the report and hand over to the patient within few minutes. So video-based digital colposcope enabling the real-time high-definition cervical imaging enhances the visualization of the pathological areas, whether it is acetovite area, whether it is a mosaic or punctation, atypical vessels, and you can take the biopsy very accurately and allows a dynamic assessment with the magnification and integrated digital precision with clinical expertise and colposcopy. So it is more accurate, more specific, and image guided, and comprehensive documentation will be there. As I mentioned to you, you can even across the continents, you can discuss and take opinions, and remote consultation is very easily available in this. So you have to select the picture and select the direct visualization, and you take the images, label them, and take the report within fraction of the second. So this is all possible, and this is a very high resolution pictures compared to the manual. And the last point is the learning is also going to be very differently enabling the students to learn, because it will be more accurate and more specific and more useful to the students. So with this I conclude. I also request, artificial intelligence is our theme of Femicon. Every year I conduct one conference, thematic conference. Various endoscopy conferences I have conducted, and this time the theme is artificial intelligence in obstetrics and gynecology. Kindly make a note of the date, 11th and 12th of July. I invite cordially all the pioneers to join and all the young students to join. Thank you. Thank you so much.
Thank you so much, ma'am. Thank you, ma'am, for such insightful session. I request our chairperson, Dr. Bharti ma'am, Dr. Beena ma'am, to give their valuable opinion.
Yeah. Good evening, madam. It was, as usual, very nice presentation. And when I heard that AI is going to be discussed, I thought your name only because always your presentations are AI based. So I really appreciate it. One point only I want to ask is when we do a colposcopy, we see the images, usually these are 3D images. But when we store them, they are not a 3D. Does it going to make some difference in interpretation when we use the AI images?
Madam, this has a network. You can even do dual, as you said, 3D. Like 3D laparoscopic cameras, we have no, madam.
Yeah.
3D images also we have. But when we give printout, we'll give in 2D only. But in future, we don't know. We may get the 3D images, just transmit them, and patient can see their images on their screen. When we read about AI, it is becoming mind blowing whether we can cope up with the so much of advancement.
Right.
The future is will be very, very amazing.
Yeah.
I feel even
That's
the laparoscopy, hysteroscopy, colposcopy, the future we need not give the print. We will just share the 3D images to them and they can see in their screen the 3D pictures. The future is going to be like that.
okay, madam. Thank you.
Yeah.
Thank you so much.
Thank you, Dr. Bharati.
Yeah. Yeah. Very good evening to all. Uh, Dr. Famita, you have covered everything in so much in detail about the AI. And
But
what I want to say regarding my own experience regarding, are you doing the AI-based screening in your own place? Because AI is very important for the cervical cancer screening. And what I observe that when we are doing the screening, because we have the small instrument Cervacare, and what I observe that AI is definitely play very important role in faster diagnosis and very important reporting. The reporting is at there and there times when we are screening. And every Thursday and Saturday, I'm going to the grassroots level in villages where I'm doing the cervical cancer screening by the via assisted with AI. And what I observe, my own observation, that out of the 1280 patients, 87% patients showing the normal report and only the 13.8% showing the abnormal. And this 13.8 further I referred for the medical college for the HPV DNA and colposcopy. So patient, what I observe there is for the grassroots level. If we really want to do the screening, the AI based via test the best for the screenings. At least 87% we can come out with the normal, and whatever the 13, 18, 14%, we further go for the screening. But every time, whatever you had said about the AI role on HPV DNA and colposcopy and dual standings, but that is at the tertiary level. But our aim is to screening the cervical cancer at the grassroots level. So for that, it is the important. There and there give the report normal, abnormal, atypical, high grade, low grade. So immediately we screen out the patients, which patients should be referred. And that is the what my own observations. It is very important for the what we want because 96, 70, 90 patients, 70% screening we cannot reach by simple pap smear or HPV DNA test. We have so many tests. But if we go with AI with via component at the grassroots level, we definitely reach our goal. And that is my observation personally, which I am doing in villages. Most of the Jamma Ramgarh, nearby here.
Thank
I
you.
have
Thank
very
you so
high
much, ma'am.
respect for you and your expertise. Let me clarify the point. Maybe it is just an introduction of 15 minutes. I could not have impressed you. In fact, the AI based reporting is to reach the level what you are doing the remote areas. Why? Because the image itself from the remote area where there are no experts, like you are a benchmark in the colposcopy, whereas a remote area, a small health worker is putting this AI
Yeah, they are doing
incorporated
it.
colposcope. It will take the picture, it will transmit to you, it will transmit to the medical college in a fraction of a second. It gives the report.
Yeah, and that is true. But even if we go for the via with AI test, no, then there they gave the report abnormal, normal, and atypical there by the Servicare instrument which I'm using. So that I'm just immediately within a 60-70%, 70 patient I screen in one day, which is not possible with the PAP test or any HPV DNA test. But in the village, I am screening. So I am very much happy that we are not going for. But whatever the abnormal results I observed, I sent them to the test in my Mahila Chikitsalaya hospital, and they are giving the HPV DNA test, colposcopy. So patient is also satisfied. And out of that, whatever the abnormal, in that 2.1% is the false positive. So that is the important report, which because spastic metaplasia sometimes give the report something. So at that time, the clear-cut picture will be coming out that only the 1 or 2% patients showing the false positive. Otherwise, our results are absolutely normal.
That means you are already using AI, isn't it, madam?
Yeah, I am doing regularly in my practice.
Thank you. Thank you so much, ma'am.
A
Pamita
person
ma'am.
like you is endorsing AI means it is a great thing, madam.
Yeah,
Thank you.
because
Thank you so much,
because
ma'am.
it does not require any assisting with me.
Thank you.
Pamita ma'am, can you please stop sharing your screen?
I stopped, madam.
No, ma'am, it's just the PPT has been closed. Yeah,
Yeah.
thank you so much, ma'am. Thank you.
Thank you, Dr. Bharati ma'am, Veena ma'am, and Dr. Fahmida ma'am for your valuable comments. We are truly honored to have all of you. Moving forward to our next session on real world experiences and myth. Chairperson for the session are I welcome Dr. Aruna Nigam ma'am. I welcome Dr. Aruna Nigam ma'am, President of ISCCP and ex-HOD of HSC Hospital and President of NARCHI. Ma'am has published more than 250 articles in various national and international journals, and ma'am have been editor of various books. Please share the screen.
Already done. You are not able to see?
Okay.
Okay, don't worry. If you are not able to see, I can introduce, ma'am.
For our next chairperson, I welcome Dr. Sarita Shamsundar ma'am, professor and unit head of gynecology oncology at Safdarjung Hospital, chairperson of FOXY Gynecology Oncology Committee, and chairperson of Oncology Committee at AOGD. Ma'am has conducted many research projects in cervical cancer screening. I welcome both of you, ma'am. The session is presented by Dr. Arpita Anantraju, ma'am, additional professor at JIPMER. She has been principal investigator for multiple ICMR and ANRF project and nodal officer of MCH programs. Ma'am, over to you.
Yeah, can I start sharing the screen?
Yes, Dr. Arpita, you can start sharing your screen.
Is it visible?
Yeah, it's visible.
Yeah. Good evening, everyone. Thank you for the opportunity, Dr. Aruna ma'am, Dr. Bindya Gupta ma'am. It's an excellent platform to present to the teachers of colposcopy across the India. Honored and humbled to presenting my work in this small world. So the topic is AI in cervical cancer screening. I'll be talking about what we are doing here at JIPMER. Coming to why AI is needed, probably Famida ma'am has already spoken, but yeah, I will be brushing it soon. So India has a global burden, carries around 18% of global burden of cervical cancer, but unfortunately we have only less than 2% of screening coverage. And we are targeting to achieve WHO target of 70%. Which, as Madam told, is very much not possible without AI to scale up. So the challenges that we have with the current screening techniques is one, the high cost cytology based screening, HPV based screening, lack of human personals, and highly subjective via and standard colposcopy. With this, the need of the hour is cost effective point of care diagnosis and AI based screening to reduce the interclinician variability and to reduce the burden on clinicians. So what is AI and how does AI fit in cervical cancer screening? When we talk about AI, we use a lot of terminologies. One of them is machine learning. It learns the pattern from the data that you give the algorithm. So that is explicitly without being programmed. When you talk about deep learning, it is a multi-layered neural network which mimics how the human brain sees and recognizes the pattern. So using this deep learning technique in AI cervical cancer screening, we can analyze the medical images, that is the colposcopy and cytology, and we can use these to act like human or superhuman to get a better accuracy. So why is it perfect to use AI in cervical cancer screening? It is basically because it is an image-based diagnosis and pattern recognition-based diagnosis. So you can have AI to do this consistent performance, which is scalable, which is very much important. As Veena ma'am told, you have to scale the screening to achieve the target of WHO. And it also works offline on smartphones. So before I jump into my work at JIPMER, I would be talking on AI, how it actually started in cervical cancer screening. Way back in 1994, the PAPNet was the first AI neural network AI system which was FDA cleared. And it was a historical milestone. Now we have proceeded 30 years down the line, and we have first FDA approved digital cytology system, which is Genius Digital Diagnostic System, which is launched in February 2024. As Madam was discussing, this pap smear based analysis using AI has achieved nearly 95% accuracy in cervical cancer screening versus 50 to 75% from conventional cytology. Coming to the AI assisted colposcopy, ma'am has already spoken about it. I would just tell about 2-3 systems. EVA system, which is FDA, SurveyRave, the video which was shown, and Sarita ma'am has validated this in India 2025 data showing in around 877 women, which was community-based screening method which was used. So these studies, the AI colposcopy agreement with trained colposcopy was around 48%. Mind you, with the amount of data that you give, AI performance will 100% improve. So what we are ahead expected is a better AI system, a better AI device, a better AI interpretation. So 100% we are headed towards betterment. So what is the system that we are developing here at JIPMER is, we have collaborated with IIIT DM Kanchipuram, Chennai, who's our engineering collaborator. We are developing a portable real-time AI-driven multispectral imaging system for early detection of pre-malignant cervical lesion. We have named it our device as GynoSight. In this diagnosis cycle of cervical cancer, from the onset to the development of cancer, and the algorithm of screen, triage, and treat, we wanted to compare our system against the colposcope rather than comparing against a screening technique, because the incidence of a screen positive in a community level is around, as ma'am said, it's around 10 to 12%. Whereas in a screen positive women, to get a high grade lesion is 100% better. Screen positive women to get a high grade lesion, it's around 12%. Sorry, I told it other ways. In a community level, we get around true positives around 1 to 2% only. So it's very difficult to validate your study in a commercial level, the community level in the first go. So we wanted to compare against the colposcope the ARS device. The first question that we wanted to answer using our device was, can we do a label-free analysis of cervix? What do I mean when we say as label-free means without using acetic acid and Lugol's iodine? Can we say just by imaging the cervix whether it is a high-grade lesion or a normal cervix or a low-grade lesion? So the biological basis that we worked and we have incorporated is the oxygen saturation mapping. So the metabolic hallmarks of a precancer is there is rapid cell progression and angiogenesis in a dysplastic epithelium. And there is an aerobic glycolysis leading to hypoxia-driven gene expression. So the oxygen saturation mapping in the various tissues are significantly different. When you compare normal CIN1, 2, 3 and invasive cancer, the saturation of oxygen is significantly different. So how do we actually capture the oxygen saturation mapping? We use different illuminations using different wavelengths, and we capture different wavelength light images, and we do hemoglobin analysis using oxyhemoglobin and deoxyhemoglobin using various ratios of wavelengths, and then the oxygen saturation mapping is done. Coming back to our device, how does it look? How did we start from the scratch? This is an outset of our device. It has an optical end and multiple wires and optical system. The electrode module is something which is compact. It's portable and it can be clinically deployed in an OPD or in a community setup. We started with prototype with chip-on-tip method. Second prototype is the time which we got approval and funding from ICMR. We improved our device using lead pipes, light pipes. Third prototype, we had, again, we bettered ourselves using a biocompatible material to sleeve our probe. In the fourth prototype, we had 4 LED wavelengths cross diagonal. In the fifth prototype, we improvised our lenses to 5 megapixel lenses with a better resolution. In the sixth prototype, which is the current prototype, we have display on itself with a 20 megapixel camera, integrated real-time analysis, and an excellent resolution with 4 LED per wavelength lights. Coming to the oxygen saturation mapping, images are acquired using different wavelengths and image registration is done, followed by oxygen wavelength oximetry. I will not go into the technical terminologies. This is how it looks when you take different wavelengths photography of the cervix. First will be label-free images, followed by acetic acid and Lugol's iodine images. We segmented the cervix. We annotated the cervix, the transformation zone. We also annotated the abnormal vascularity. So our device can actually map the transformation zone, internal loss, and also the external loss, and also the various abnormal vasculatures. Coming to the correlation of the biopsy and the colposcopic results, this is something which is work in progress. We have published our paper with significant amount of patients, but not good enough to say that it is validated. So we marked our oxygen saturation across the 12 clocks of cervix and we correlated with histopathology reports. This was something which was done for the cone patients who underwent cone biopsies. Only for them we could get biopsies from all the 12 clocks. And we were to some extent able to say the dysplastic epithelium correlation with oxygen saturation mapping. The next question that we wanted to answer was real-time mapping of the lesions. As ma'am showed, most of the images are captured and then fed to the algorithm to give the results. But we wanted something which is real-time when you are actually capturing. So we worked on that part also. So we captured the images, we segmented, we annotated the images, and we trained our modules using different algorithms. So the real-time implementation of the AI model was done. When you're actually capturing the images in real time, you can get a bounded area of lesion being marked on the display. So this is, we are deploying our device at Jepmer and you can see a bounded area being displayed. So we improvised our annotations and we actually can get in real time the geographical area of acetovite areas and also iodine negative areas with good accuracy. So we published this part of our work, that is real-time detection of pre-malignant lesions in EJOG in 2025. And the result was the AI performance has nearly FI score of 90% and a map of 91%. The clinical accuracy with iodine negative was 86% and with acetic acid was around 85%. When we compared our algorithms with algorithms which is there in the literature, our algorithm was having an accuracy of 86% and the sensitivity of 87 to 92%. This is basically because we trained our module both for the video and the static images. So the number of the feed for the algorithm was significantly good. That could be the reason for better accuracy and sensitivity compared to the literature. Another component that we trained our module was detection of internal loss. So we have to keep in our mind that AI gets trained to only things that we tell. For a clinician, we will be able to locate the internal loss, the cervix, the transformation zone. But AI needs to be trained every component. What is cervix? How does it look? And another component was that we trained was the percentage of cervix that is visualized. So in order to tell whether there is adequate visualization of cervix, we also need to quantify the amount of percentage of cervix that is visualized. So that was one more thing that we have done. So our system, when you see the AI detection in real time, we have an OS detection, cervix amount of percentage of cervix that is visualized, the transformation zone being marked, the
Dr.
diagnosis
Arpita,
being
sorry to
identified.
interrupt.
Yeah.
2-3
Yes,
minutes
ma'am.
remaining.
Yes, I'm done. Another two slides.
Okay, thank you.
The aceto-white area being detected, iodine negative areas being identified, and oxygen saturation mapping being done. Another component that we are working is autofluorescence, high resolution microendoscopy, and electrical impedance. So the clinical implication is one, the interclinician variability from the traditional via can be improvised and we get an accurate diagnosis. The translational success is supporting the tool in low resource screening environments. The limitation in our module is overdiagnosis of inflammatory changes that we are working now. The future scope is again multi-institutional trials. We have applied for funding, and if we get a better algorithm, is in future. I would 100% acknowledge the entire the students and the staff, my engineering collaborators from IIIT DM Kanchipuram and IISc Bangalore, our industry collaborators, and our funding agencies, that is ANRF, ICMR, and the previous. Thank you so much for the opportunity.
Thank you, Dr. Arpita ma'am, for such wonderful and insightful session.
Thank you, ma'am, for sharing for your real-time experiences.
Thank you,
Yes.
ma'am.
Thank you so much.
Welcome our next speaker, Dr. Jyoti Meena ma'am. Ma'am is Joint Treasurer of ISCCP, member of Foxy Oncology Committee, and member of Education Committee of Asian Society of Gynecology Oncology. Ma'am is also member of Foxy Oncology Committee and received various awards in her field. Ma'am, over to you.
Thank you, Priyanka, and thank you, Nidhi, for for giving me this opportunity. I have heard Dr. Famida and Dr. Arpita. I think everything has been covered on AI. So I will be just focusing on the device which we are using. So it is a newer device, and it is basically an initiative led by IARC. So I will be talking about this device. So we all know that cervical cancer is a public health problem, and India shares 1/5 of the burden. So this IARC has led a research initiative for this cervical cancer initiative by the name of Save Cervix Project. That is systematic and automated visual evaluation of the cervix. The aim of this project is for developing and validating AI tools to improve cervical cancer screening, triage, and management in low and low middle income countries, with clinical focus on scalable, accurate, and cost-effective support via specialist colposcopy infrastructures limited. So basically, it involves AI development, clinical evaluation, and also to have partnership and collaboration with other countries, and to have an image bank of colposcopy. So this Save Cervix project, it bridges the diagnostic gap through automated visual evaluation, that is from the point of care screening to immediate treatment. And this device, it creates a closed loop system which is capable of screening, triaging, diagnosing, and defining the treatment parameters. So basically, this is a prospective multicentric trial, which includes India and Thailand. So in India, we have New Delhi, where AIIMS is a part. In Kolkata, CNCI is there. And in Chennai, it is the Cancer Institute. And in Bangkok, it is the National Cancer Institute, Thailand. So the main target is we have to enroll 10,000 participant targets, and the aim is to enable the screen and treat module. So here we are doing screening, triaging, and in the single either sitting, either treating or reducing the visits. So about this device, if I say it is an AI-assisted colposcopy platform, which is designed to augment the clinical decision making. It provides a prescriptive workflow And it also displays images which are AI-driven visualization and annotations for interpretation. And it offers a diagnostic support while clinical decision always remains with the clinician or the colposcopist who is working. So if we talk about the ergonomics and optics about this device, it has a tablet, which is 7.1 touch-based tablet with and keyboard inbuilt with a detachable orb, which houses a 3.4 megapixel CMOS sensor and LED. And it is this mounts on a stand, which I will show. And there is a software is embedded within it, which dictates an automated sequential capture process. So this is the device, basically. This is the stand and this is the orb, which is fits in, it slides, basically it slides in this socket. And this is the LED, this is the light source, LED light, which is the narrow band imaging system it uses, and it has a liquid lens. So even at the low voltage, it alters the lens curvature for instant focusing of the asymmetrical or curved transformation zone. These are the two knobs you can see on this. One is shows this camera picture, which is for capturing the picture. So the person who is doing the colposcopy can either capture the image from here, or one who is sitting on this tablet can click from there after focusing. And this is for zooming in and zooming out for magnification. So this is the device. And this device is FDA and CEDASCO approved and is ICO and ISO and IEC certified. So basically, it provides a guided workflow, AI visualization, and decision support. So it is based on an ICAR engine, that is the Intelligent Cervical Assessment and Recommendation, which uses dual modal assessment. That is, it uses acetic acid AI model as well as the Lugol's iodine AI model to finally give a combined high precision output. So this is basically the prescriptive clinical pathway that first we take a pre-saline image, then a saline with after cleaning with saline green filter, then acetic acid. In this acetic acid and saline, it gives along with green filter. The images are with green filter. Then there is another thing that you can map the squamocolumnar junction also. It gives a pathway that is locate the squamocolumnar junction, then Lugol's iodine. And finally, you can mark the worst areas from where you need to take the biopsy. And these can be captured as well, so that if you want to see in future, you can see where were the worst areas from where the biopsy is taken. So it provides a standardized workflow, objectivity, and accountability, as all the images are linked, are uploaded in iCloud, and you can link these images with the final histopath or the biopsy report. So why there is a necessity of double confirmation? Because it helps in redefining exam precision by requiring dual stain verification to escalate diagnostic severity. So both the acetic acid image as well as the Lugol iodine model, both are used, and then after assessing the SWEDI score, it gives an AI prediction. So it can work offline. You can take the pictures. So for the taking the pictures and saving on the tablet, you don't need an connectivity or Wi-Fi. So it is offline at the point of care. And the connection is only required when you want to send it to someone for review, or you want to store it on the iCloud, or you have to send it for the expert to give you a opinion. Then only connectivity is required, but it is good to connect it and save it in the iCloud so that you can even access it on your desktop also. So this is, and it can be used even in the remote setting also. So it is basically provides a screen and treat single visit approach. You can examine, you can compute the findings, you can decide, and then you can finally treat as well. So this is how it looks like in a clinical workflow. It is a saline image picture along with green filter, the aceto white one, where you can see here the aceto whitening is there, then Lugol iodine. And in this worst area, you can mark, there is a pencil where you can mark with cross the area where you need to take a biopsy. So it provides a consistent visual record across the steps, helping in identify the most suspicious area and link the clinical impression to biopsy and histopath. So for this patient for which these images are there, it gave the AI prediction it gave, because the SWEDI score came out to be 4. So it gave a probability of 96% being it normal or CIN1. So we did a thermal ablation in the same sitting as the patient was having postcoital bleeding and discharge. So thermal ablation was done looking at low-grade lesion, and final histopath was suggestive of chronic cervicitis or inflammatory changes with no evidence of malignancy or dysplasia. This is how the report comes. This is of another patient, but if we want to give a report to the patient, we can even give this printed report as well with the different pictures of saline, pre-saline, acetic acid, leukals, and even burst area. Then this is another patient who came to us with in this project, we are only taking the HPV positive women who are coming for colposcopy. So again, she was an HPV positive woman with a complaint of irregular cycle and discharge. And this was the colposcopic finding, pre-saline, saline, then in green filter, then acetic acid. Here we can see a dense acetovite area, and here shady white. Then this is this what I was saying, that it also gives to locate SCJs. So you can draw even the SCJ and can save the picture. This is leukals iodine, and here you can mark the worst areas which can be seen during colposcopy. So this is how, while we are calculating the Swedish score, it gives a reference. So there are reference images which are feeded in this. So if anybody has a confusion about this, then they can refer to the reference images and can give a Swedish scoring. So this is just a few pictures showing the referencing. And for this patient, though the Swedish score was 5, but the AI took into account both the pictures and gave a probability of 64% as normal or CIN1 and 32% as CIN2. So we have done this patient recently only, so we will follow her, how her histopath comes out. So this is how it gives the AI prediction. So till now we have done 102 cases in for 5 months, and we have performed biopsy in all the patient, and till now 93 biopsies were analyzed, and out of which 9 were CIN2 plus, while AI predicted 14.7% as high grade lesion. 2.9% had a unsatisfactory examination as well. So based on this observation, it provides a standardized examination. So there is a prescriptive sequence which reduces the variability in image capture and documentation. Their image can be recorded and could be linked to colposcopic impression and final HPE outcome. Unsatisfactory impressions are low till now. The device can work offline during examination and is used for clinics and outreach settings. And the images and structured output support same-day counseling and even expert review as well as treatment as well. So to summarize, this is the AI support only supports final diagnosis of the clinician. So the AI can give you a standardized workflow. It can enhance the visualization. This device, it supports biopsy targeting, giving the worst area. It creates an audit-ready record so that you can audit your colposcopy images later on, and can even share it with experts for an opinion. And it is a portable offline device with a cloud sync when it is connected. So I think the AI has revolutionized this era, but still AI is doing it works, but the clinician diagnosis and decision is what matters. So thank you. I think this is what I wanted to present.
Thank you. Thank you, Dr. Jyoti ma'am, for giving detailed overview about AI devices. And the session was very insightful and wonderful. Moving forward, I now welcome our next speaker, Dr. Nidhi Gupta ma'am, professor at HSC Hospital, Joint Secretary of ICCP, and member of AOGD Oncology
Thank you, Priyanka.
Committee.
Are my slides visible?
Yes, Nidhi.
Yes, ma'am.
Okay, they are moving?
Yes. Yes.
So good evening, everyone. Up till now, we have learned a lot about AI from the experts, from the stalwarts. But I just want to say, any new thing doesn't come alone. Always it comes with the challenges, or I would say some dilemmas. I have tried to make that challenges in form of small case scenarios, 1 or 2 scenarios, and some related questions. So first is a 40-year-old woman in a rural clinic screened using the AI assisted VIA during a camp survey, and the result is came out to be positive. There is no specialist available nearby. Are my slides moving? So the treatment should be started immediately. It's just like we did do in WHO, that is screen and treat approach. We can start the treatment if the criteria for the treatment is met, and if we are sure that that lesion is not suspicious of a high grade. It's better to evaluate the high grade lesion at a higher center, and if criteria for the immediate ablative therapy is not met. Next question raises that risk of over treatment versus loss to follow up. This is same as we are doing VIA at any low resource setting. In a if we overtreat a lesion, or we can lose the patient. So at a low resource setting, loss to follow up is a more grave health threat to a patient rather than the overtreatment. So these two challenges are also with VIA, which we are doing in low resource settings. And they will also be there when we are doing this AI assisted VIA. So next question arises, can AI replace this expert colposcopy in a low resource setting? As of now, it is an adjuvant tool, or we will say it is a supportive tool, because AI works basically, we have learned from Dr. Famida as well as Dr. Arpita and Dr. Jyoti that it works on the quality of various images we fed in AI. So if the quality is good, it gives a good result. If the qualities are not that good, it cannot be able to give that good result. So it largely depends upon what type of data we have fed in the AI. So it cannot presently replace the expert colposcopy who do the dynamic evaluation of all the parameters of which we found on the colposcopy, like vascular parameters or acetovite areas. So after this, can AI models be generalized across all the population? This is a major and critical limitation of AI in the present situation. What is this generalizability? That means any data which is fed in the AI, if it is data is used on the Western population, it cannot be used on Indian population, because AI models work on training data set, device variability, and operator technique. So any data which is fed in the AI before using to the local population, there should be a local validation of that data on that population in which we are using these AI models. So it cannot be generalized across all the population blindly. It should have the local validation. So now the same patient, if come out to be HPV negative, so AI has generated a different report, but if we have done the testing, it has done the, so there is a discrepancy between them. So which test takes the priority? It is same if there is a any query or any confusion between any of the reports, expert opinion, better to refer that patient. So such patients may have, they have the anxiety of unnecessary procedure, or they may have think, I don't know what is going through, I don't know which report is correct. So how they can be, overcome? So proper counseling should be done by the AI provider or the AI provider who is using AI at the time of screening only. That what can be the shortcomings or what can be the limitations of AI system which I am using. So the next case scenario is a patient lesion was missed by an AI screening tool, but later diagnosed as cancer. So clinician relied on the AI report. So for this, who is responsible? A doctor, a hospital, or AI developer? Presently, AI is not a individual authority to become the responsible. So if the doctor has used the proper management guidelines, hospital is using the adequately validated AI system, and the AI developer has used the data which is unbiased. Developer has not used any false claims like it can do this then that, which is not been fulfilled by the AI instrument, or any limitations which are not very much clearly defined by the AI developer. If all these things are properly and adequately followed, then no one can be held responsible for the it's just like the any instrument who is showing the any faulty report or anything missed on the basis of if the triaging or the symptoms or the patient has been seen by some junior person. So should the final diagnosis always be expert verified if we are using this AI system? Present scenario, it should be yes. And why is it so? Then what is the advantage of using AI? But in a high stake conditions like cancer, it should be expert verified. As AI system has false negative as false and false positive values, there are certain rare and atypical presentations, the data of which may not be fed into the system. So when there is query or some high grade reason of suspicion is there, better to be evaluated by an expert. If there are persistent symptoms and AI modality is showing normal screening or the normal test, in that case also we should seek an advice of an expert. So to conclude, I would say AI will augment, not replace the clinical judgment. It has not set any medical legal guidelines, and it has largely depend upon the data which is fed into the AI system. There is one question, that is a data protection safety. I have seen one movie in which there is AI based AI driven auto cars होती हैं जो खुद ही चलती रहती हैं, उसमें AI system was hacked. So those cars were running here and there without any driver. So that safety, how it can be ensured? I couldn't find any articles on this also. That is how the data protection safety of the patients, which is we are feeding into the AI system. I think we have experts in our, chairpersons and speakers. They can provide more insight over this point.
Oh.
So presently, I would say that AI is not having much challenge. Basically, not adapting to AI is a challenge. Thank you so much.
Thank you, ma'am.
पागल है यार, आज भी एक गाउन फाड़ दिया.
Thank you, ma'am, for such excellent presentation. I now request our chairperson, Dr. Aruna ma'am, and Dr. Sarita ma'am to share their valuable opinion.
Dr. Sarita is there? Is Dr. Sarita there?
Ma'am ने join तो किया था.
Join तो किया
Yes,
था.
yes, yes, ma'am is there. Ma'am is there.
So please ask Dr. Sarita
Yes.
first. Dr. Sarita ma'am.
Yeah, hello, good evening, everyone. Yes, all very interesting and presentations and very promising devices. But as Nidhi said, still all of them need to be validated because AI needs a lot of data. So thousands of images are needed and correlated with the histology or an expert opinion. So don't worry that you as colposcopists will be out of job. You will still be needed. Your opinion is still needed and training is still needed of a doctor and a colposcopist as a colposcopist, because AI, if at all, it will tell you about is it positive or negative. That's it. It cannot tell you about how you're going to manage. So that is definitely it is the clinician's prerogative. So it is definitely useful for screening. So AI is useful for screening, but for the further management and planning the management, it is you as a clinician who is going to be important. So thank you all once again for this great session. Thank you for the invitation, Nidhi and Aruna.
Dr. Aruna, just to
Yes,
comment.
I want to say something. So AI is for assistance, not to replace. That is very important point which one should take care of. So you have to put in right prompts for the AI use. You have to use right images, right things for AI use. And ultimately comprehension over and above what AI has given has to be maintained in a manner that it should be evaluated how your patient is, what is the compliance of the patient, everything need to be considered. The second point which Dr. Nidhi wanted to be explained regarding the data protection. So there is a DPDP Act which has come and lot of discussion is going on, and you are going to be confused once it's implemented completely, and then maybe e-prescription you are not going to write down because there are many things in that. Your whatever AI based system you are using to preserve your data, that is a cloud server. So that cloud server should not be out of India. So if your data is going out of India,
So whenever you are taking a help of AI, you need to see the what cloud service or what program they are using. So if it is going, you can be charged with around 200 crores rupees for sending the data outside, because it can then be utilized. So these are very finer points. Whosoever is making few of the programs just for their help, out of their interest. So whenever you are anything, any small thing, patient data, even a blood pressure which you are keeping with you, should not go to out of India. Otherwise, this much of penalty is there. So you need to be very careful whenever you are using a AI, where your data, the question should be where your data is going, who is going to utilize your data, who has a access to that data, because you have purchased some program, right? But what will happen to the base of that data? Who can, other persons can access? So जैसे आपको देखते हैं ना व्हाट्सएप में होता है एंड टू एंड इनक्रिप्टेड, कि आपका डेटा, आपके messages कहीं नहीं जा सकते. So those are the things which need to be considered whenever we are using the data, and that is the thing which is coming into DPDP Act. So that is a quite big topic. So a very nice presentation by Dr. Arpita, Dr. Jyoti, and Dr. Nidhi. Thank you for inviting me as a chairperson. I think Dr. Fahmida wanted to say something.
Wanted one good point Dr. Nidhi told. So the data what AI has to be our regional based. This is called as algorithmic bias.
सारा तो खा सकता है और भी
It,
रखा
it gives inference
क्या था
depending on what it.
यूरोप में जो दिखाया था वो था और भी एक और पेशेंट लेकर आया था.
Dr. Kavita, kindly mute yourself, please.
What Aruna has told is autonomy. It is also very important point. Medico-legal is very big issue. This algorithmic bias to overcome, we should have our data. So all our data has to be compiled to give our region area women the accurate report. As she correctly told, we cannot compare this data with the Western people or African region people. That is a very important point Nidhi has told. I really appreciate. Thank you, Aruna, for giving us. Thank you, all of you. It was a wonderful meeting all the pioneers. It is really, I am privileged. Thank you.
Best thing is that it is finishing in 70 minutes.
वही मैं बोलने वाली थी कि थैंक यू मैम, मैंने टाइम में खत्म किया है, मुझे एटलीस्ट डांट नहीं पड़ेगी अब.
Thank you,
Yes,
Aruna
all
ma'am.
good.
Thank you, Dr.
Thank
Nidhi.
you.
Thank you all.
So
Thank
you
you,
all.
everyone.
See you.
Now I invite Dr. Bindya to give the vote of thanks.
Yeah, what vote of thanks, Nidhi. You did such an absolutely fantastic job. And I think whole credit to you for getting all these excellent faculty on board, which had such interesting lectures. Femida ma'am, you were like really a rock star. And I tell you, it was really interesting listening to you. Jyoti, Arpita, and Nidhi. I mean, all just fantastic, crisp talks. Excellent. So thank you very much for a very, very interesting webinar. Thank you all the chairpersons for pitching in for their valuable opinion, Bharti ma'am, Veena ma'am, Sarita ma'am, and Dr. Aruna. And very nice webinar, and kudos to, I think, let's see how we have another look at the AI in next year. So maybe let's see how this webinar phases keeps pace with the next year when we have it after 6 months or maybe 12 months. So let's see how we'll go back to this webinar again. Fine. So great. So with this, we sign off today, and again next month, 7th of June, 7 p.m. for 70 minutes. We all will get together, and very, very interesting topic. It's on extended genotyping for HPV. Dr. V. Priyanka is going to be the convener for this. And as you all know, after AI, it is now the numbers of HPV, 16, 18, 45, 52, 59. Everybody is all confused. So we'll give you like nice, crisp recommendations regarding all these numerical jargon of HPV. So with this, we sign off today. Thank you very much, the conveners, Dr. Priyanka, who was your MOC. Thank you very much. And thank you, Dr. Aruna.
Thank you, ma'am.
Thank
Thank you,
you.
ma'am.
Good night,
Again,
everyone.
777.
Yes,
Yes.
777, exactly. So we have a
Wonderful.
great
Yeah.
this thing. Thank you,
Thank you.
everyone.
Good night.
Thank you, ma'am.
Bye.
Good night.
Bye.
Thank you.